I'm going to go through new diagnostic modalities and new therapies. I'm also going to talk about some old ones as well, because I think it's important. So we've talked about reflux disease. It's common, we know the symptoms, and we know that it can be troublesome and refractory. When I'm looking at reflux and I'm wanting to investigate reflux, what are my real aims? I think number one, I want to know which patients really have gastroesophageal reflux disease and which don't. And also I want to identify those patients whose symptoms are due to reflux. Just because you have reflux, it doesn't mean that your symptoms are caused by it. They may be coincidental. So that's another important aim of our reflux monitoring. And we want to know which patients are going to get better from treatment. There's no point doing a test unless it will help us decide on a management plan. And of course, it's obvious we want to treat the symptoms. So although I'm talking about new modalities, I think it would be wrong to ignore acid, because acid is fundamentally important in most reflux disease. We know that the more severe the injury, the higher the acid exposure. Patients with Barrett's esophagus have a higher acid exposure on average than patients with non-erosive reflux disease. And we know that if you give intraesophageal acid infusions to patients with reflux, if it's a pH of 1, 1.5, you will cause symptoms in everybody. The higher the pH, the less likely you are to cause symptoms. So acid is important, and we shouldn't forget that. So when we're identifying patients with reflux disease, there are easy ones. This is easy. A patient's got esophagitis and heartburn, they have reflux disease. We don't have to go too far down the diagnostic algorithm to get to that point. You do an endoscopy, you make the diagnosis. When you have no erosions, that's when reflux studies can become helpful. And so if you have a patient with a completely normal esophagus, but you do a pH study and it shows lots of acid reflux, that is still reflux disease, of course. That's non-erosive reflux disease, which is probably the commonest phenotype that we see. So some people would say up to 60% of reflux disease is not associated with erosions. And so we're on our diagnostic algorithm. We've done an endoscopy, it's normal. 24-hour reflux study is positive. They've got non-erosive reflux disease. Again, it's relatively easy. It's when we get into the normal acid exposure groups that things can become a little bit more complicated. So here's a patient with normal esophagus on endoscopy, physiological 24-hour reflux study. So if there's reflux, I said maybe, maybe not, maybe I should put it the other way around. Probably not, but maybe. Now there are a couple of options here, and this is where we start looking at whether the symptoms are related to reflux or not. And so we have our algorithms to look at the association between reflux and symptoms. The commonest ones we use are the symptom index and the symptom associated probability. The symptom index is a fairly crude measure whereby we look at whether a symptom event was preceded temporarily by a reflux event. And as a relatively arbitrary figure, if more than 50% of the symptoms were preceded by a reflux event, that is considered positive. The symptom associated probability is a little more statistical. It's where the 24-hour period is divided up into 2-minute intervals, and in each of those intervals, was there a reflux event, was there a symptom event, and were the two temporally related? And you can be put together on a 2x2 table. A Fisher-Exact test is done. If the score of that is more than 95%, then it's probable that the symptoms are related to each other, and that relationship is not due to chance. So this is how we work out symptom association. There are flaws with this, and that could be an entire lecture. But we do look at that, and that's the best we've got. And as a very quick measure, if you have physiological acid exposure, so you don't have too much acid, but you have a positive association between symptoms and reflux, it means that you are sensitive to acid reflux. And that tends to be treated by reducing acid as best you can, so people tend to give high-dose PPI, but also reducing the sensitivity of the esophageal afferent nerves, and there is evidence that medications such as citalopram can help with that. On the other side of our diagnostic algorithm, when we have a physiological acid exposure but no association between symptoms and reflux, that is what we call functional heartburn. And in these, again, medications to reduce sensitivity tend to be useful. There's evidence, for example, for fluoxetine, so again, SSRIs, and most people would consider tricyclics in these situations as well. But it's not always that simple. So one of the things that we're always concerned about is if we've got this normal endoscopy, normal reflux study, the most likely thing is that it is functional heartburn. But what if it is reflux, but the symptoms are caused by acid? The reflux isn't just acidic. You've got bile acid, you've got pepsin, you've got bacteria. That may be possible. But what if it is reflux, but the day when the patient had a tube stuck in their nose, they didn't really feel like eating very much, and they didn't do what they normally do, and it wasn't a very typical day? That's also a possibility. So when it comes to looking for non-acid reflux, this is where impedance helps us. So with an impedance catheter, we're not just measuring acid in the esophagus, we're also measuring the impedance at different levels throughout the esophagus from distal to proximal. And what the impedance does, there are pairs of electrodes, and these are measuring the impedance to electrical flow between each pair. And that flow cannot happen through the catheter, it has to happen around the catheter, conducted by whatever is next to the catheter. And during a reflux event, what is next to the catheter of these electrodes is a nice ionic gastric juice, which can conduct very easily and is therefore associated with a low impedance. And we can track that movement of impedance, so we can see impedance changes that happen first at the distal esophagus and make their way up, and that's a liquid reflux event. If a patient swallows, you see that drop in impedance happen at the top of the esophagus and make its way down to the bottom. So occasionally you see a patient who's drinking lots and lots of Coca-Cola, and even though their acid exposure is positive, you can see that they're drinking it. That's not reflux disease. But impedance means that we can see acid reflux events, weakly acidic reflux events, and also completely non-acid reflux events. And there are some people who found that this may well be associated with symptoms in refractory disease. It's a little bit contentious, but certainly there are a proportion of patients who have symptoms that are due to non-acid reflux. And it's possible that these patients may benefit from anti-reflux surgery because the PPIs are not going to help. And just as a quick note here, this is a study which looked at which parameters of reflux studies predict outcome to therapy. And importantly, just down the bottom, if you look at the symptom-associated probability for just acid, actually not a great predictor of response to therapy. If you look at the symptom-associated probability for all reflux events using impedance, so that includes non-acid reflux, then you start being able to predict outcome to therapy. So it seems that these non-acid reflux events do have an impact on deciding what we're going to do. This is another quick note. I don't know how many people see things like this, but this is a pH study that shows lots of acid reflux. And if you just have the pH here, you might send it to a friendly surgeon to do an operation. If I look at the impedance, there's lots and lots and lots of spikes. And these spikes are poorly conducting material. This is air. And this is a patient who, if you had them in front of you in clinic, would be belching and burping in front of you. I don't know how many of you see this. This is something called supragastric belching. This is a behavioural phenomenon. The patient sucks the air in and expels it. This isn't a normal belch coming from the stomach. This is a behavioural sucking in and expellation of air. And sometimes this can be associated with reflux by causing an opening of the lower esophageal sphincter. And this is where another thing where impedance can be really helpful. If you operate on these patients, supragastric belching gets worse. There are studies to show this. So again, impedance can help us in this situation. Because we're looking at new developments, I'm not sure there's much that's not particularly useful beyond here, but what we can look at is baseline impedance. The impedance when there's a liquid reflux event, it's that liquid which is conducting the current between the impedance probes. When there's nothing happening and the esophagus is empty, the esophagus is collapsed against the catheter, and what you're measuring is the impedance, the current flow through the esophageal mucosa. And actually the esophageal mucosa becomes more leaky in reflux disease. And so if you have a lower impedance to current flow in the esophageal mucosa, that may help you diagnose reflux disease. Now, we've looked at that, other groups have looked at that, and there's definitely a lower impedance in patients with reflux disease versus patients who don't have reflux disease. And some people are starting to advocate this as part of the diagnostic algorithm. I think what you can see on our study on the right-hand side is there's a lot of overlap there. I think this is not good enough yet to be used as a diagnostic criterion. But just be aware, when you do an impedance study, if you look at the bits in between the reflux events, if that impedance baseline is very low, think reflux disease. If it's incredibly low, think Barrett's esophagus. LPR, so laryngopharyngeal reflux, is a really difficult area. Standard pH and impedance has not been found to be very helpful in predicting outcome and detecting it. And there was this theory of aerosolized acid in LPR. So the idea that it's acid vapor that gets to the pharynx and the larynx and causes the laryngitis, the hoarse voice, rather than liquid which would be detected on a pH probe or on impedance. And so there was something called ResTech developed. I don't know if that ever made it to Egypt. And what it was is this very small probe that sat in the back of the pharynx. In fact, it still does exist, sits in the back of the pharynx and is supposed to be able to detect aerosolized acid reflux. And the initial studies were quite optimistic. It showed that we found a positive result from this pharyngeal probe was associated with a better outcome from treatment. Unfortunately, it hasn't been able to repeat that. And the study we did found very little. So we did a study where we used a customized impedance probe, which was a bifurcated probe where part of it sat in the esophagus and part of it sat in the pharynx. And unfortunately, we could see no correlation between reflux events happening in the pharynx and on impedance and on ResTech a lot of the time. And even when we saw an obvious reflux event on impedance, we sometimes didn't see any change in the ResTech probe. And I think now the ResTech probe is falling out of favour. Another potential new development is looking at salivary pepsin. Again, I don't know if this has made it to Egypt. I mean, this is something which is becoming increasingly commercialised in the UK, with the idea being that it's a very good principle in that you don't just have acid coming up, you have the other contents of the stomach, including pepsin. And so one of the things we can do is measure pepsin in the saliva. And again, a study that we did showed some optimism. It's not perfect, but we certainly did see that in patients with reflux disease, gastroesophageal reflux disease, defined on 24-hour pH impedance studies, there were higher salivary pepsin concentrations than seen in functional heartburn patients or in controls. But again, there's overlap here. If you use a concentration of 210 nanograms per mil, you have a pretty good specificity, but the sensitivity is not there yet. And I think further studies that are being done are again showing there are some flaws with this test, and it's being commercialised certainly in the UK and the US. And I'm not sure the evidence is there yet to use it, but it's an enticing idea, being able to diagnose reflux in the saliva. And I think if we can master that, then it's a real advance. So what about patients who have reflux, but it's not on a typical day? Now, these are the early studies, the early pictures from impedance. The guy on the left is Stephen Shea, who wrote the original paper. The guy on the right is happily on the phone in his office with a tube stuck in his nose. Now, my experience is that most people want a day off work when they've got a tube stuck in their nose. And most people don't eat how they would normally eat, don't like to walk around. Obviously, people get reflux on a normal day for them. So the idea, and what we tell people, is to try to have as normal a day as possible. But some people don't. And in fact, it's been shown that in patients with reflux esophagitis, up to 25% will have a normal value on pH studies over 24 hours. So there's definitely a false negative rate there. So something that we can use in these situations is wireless pH capsule studies. And the most common one of this is the Bravo catheter. There's also one being developed in China called the Woodland catheter. And what happens with this, you do an endoscopy, you identify the lower esophageal sphincter level, and then using the delivery device, we can place the catheter through the mouth into the esophagus, and then with a suction and a clip, which is integrated within the delivery system, we can clip a pH catheter capsule just above the LOS, 6 centimeters above the LOS in this case. And that has a couple of advantages. Firstly, the patient, once they wake up from the endoscopy, will be walking around and they have a box but no wire connected. They're much less aware of it. They tend to eat more, they can go to work, they can do their normal things. The second thing is because it's more comfortable, you can measure over a longer period. So these capsules can measure reflux up to 96 hours. The downside is, of course, there is no impedance measurement here. This is acid only. But certainly in terms of comfort, the studies would suggest that although it's not much different in terms of placement with comfort levels, during the test, comfort levels are increased with a wireless catheter. Patients have less limitation of food intake and less limitation of daily activities. So you can reproduce a normal day. And if you look over more than one day, we find that the proportion of patients who are diagnosed with pathological reflux increases. So there are more patients diagnosed with reflux disease after 96 hours of study versus 24 hours of study. And this is a study done in Italy where they took patients who had a negative study after 1 day of Bravo capsule measurement and looked at how many then became positive over subsequent days. And you found that as the more days you studied, the more of these patients who would have been negative with the first 24 hours became positive on subsequent days, suggesting that you may increase the sensitivity of diagnosis. Of course, you have to be careful that there's a limit to this. How far do we go? Could you measure for a year? How many of us would have reflux if we measured for a year? I suspect most of us. We don't know yet what this means in terms of outcome. It's probable that some of these patients will do better with anti-reflux surgery than others. We don't know yet. We need to see what this means if you have a negative study that then becomes positive. But I think there is a real opportunity to increase sensitivity, and we use it either in patients who couldn't tolerate a 24-hour reflux study with a tube in the nose, or if you think that this patient really has reflux disease but that study was negative and it was wrong, then we often use this instead. So, the last couple of minutes are going to be about treatments, because this is a bit quieter. So new medications. I've put a big black hole there. There's really not much. We've talked about new PPIs. We don't need to go over that again. There was some optimism about GABA B receptor agonists. So we know that we can use baclofen to inhibit transient lower esophageal sphincter relaxation, which are the main cause of reflux in patients without hiatus hernias. The problem with baclofen is it's tolerated terribly. I've never actually had a patient who's managed to stay on baclofen as a treatment for reflux. So the cleaner drugs such as lisagabaran, baclofen were developed, and unfortunately the clinical trials failed, and they are now not on the market. So apart from variations in PPIs, we don't have any new anti-reflux medications at the moment. Endoscopic therapies. There have been a lot of attempts at endoscopic therapies, and it's an attractive area. It'd be very nice to be able to treat reflux endoscopically without a surgeon having to cut the patient open. A lot of them have fallen by the wayside for different reasons. Two at the moment are persisting. One is Stretta, and the other is oesophagus. So Stretta is a fairly, it's a good idea. This is a catheter that's passed down an endoscopy, and there's a balloon with tiny little needles on the balloon, and basically what happens is it injects has a radio frequency energy that's injected into the muscle with the idea that it can bulk up the lower esophageal sphincter muscle and prevent reflux from happening. Obviously this needs to be done in patients without a large hiatus hernia, because you do not fix the hernia. In terms of outcome, patients seem to quite like it. The symptoms improve. Interestingly, the symptoms improve a lot more than the reflux improves. reflux does get better, but not by very much. So there's a few of us who wonder whether it's not just the muscle that's being fried, but also the nerves. But certainly patients do feel better, and it's an option. We do it in patients who are not fit for surgery in general, because it's a nice alternative. Oesophagus is an endoscopic fundoplication device, or a non-incisional fundoplication device, which is supposed to reduce small hernias, retract the hernia, and do a fundoplication from the inside. I'm not going to say a huge amount about it, except that I don't think it's got a huge amount of evidence to suggest it should be done at the moment. The PPI use is still incredibly high afterwards. Quality of life scores do improve. Esophagitis still persists in up to 40%. So I think with better alternatives, I think this is still a long way off being a standard practice. Last couple of things. So new surgical therapies. LINX is not particularly new surgical therapy, but this is a very nice device which is implanted laparoscopically, where there are a series of a magnetic ring which is passed around the outside of the esophagus, around the lower esophageal sphincter, which can expand when food passes but then contract afterwards and prevents reflux from happening. And it was good enough to be published in the New England Journal of Medicine in a surprisingly uncontrolled trial. And the outcomes were good. Patients tend to stop PPIs, so the symptom scores improve, and importantly, the reflux scores improve. And they improve to a similar level to that seen with laparoscopic fundoplication. We don't have the long-term data yet. I think whenever a foreign body is placed around the esophagus, there is concern. There was a device called the Angel Chick device several years ago, which was a similar premise, and eventually got discontinued because of very dangerous erosions of the device through surrounding organs and vessels. And we don't know where this is going, but it's got some promising data. And another thing with promising data is the endostim. Again, this is a nice idea. This is a laparoscopically implanted electrodes which provide electrical stimulation to the lower esophageal sphincter and can increase sphincter pressure, reduce transient lower esophageal sphincter relaxations, and it does improve acid exposure very well. The studies initially show that you can get acid exposure back down to normal, which you don't see with the stretta, and you don't see with oesophagus. Quality of life is also very, very good, and you see probably improvements are much better than that seen when these patients were taking PPIs. And the other good thing about this is you can do sham studies, and they have done sham studies. Very few of these other devices can you do a sham on, but with this you can turn the device off and on, and you see that it does improve in the on phase versus the sham phase. So I think in summary, even though it's about new therapies and new investigations, I think pH studies alone are good for most patients. I think that adding impedance can make a real benefit, particularly the increased value of the reflux symptom associations and the possibility to study on PPIs and visualize gas. Wireless monitoring, I think, is often better tolerated, can increase the yield of reflux and the yield of pathological reflux. We need more outcome studies. I think probably the future of additional tests means thinking outside of the pH box. I think salivary non-invasive tests are really promising, and it's something that I think patients would be delighted with if we can get that right. And new therapies, LINX and endostim are promising. I'm not sure they're better than the fundoplication. Fundoplications are very good in the right hands and in the right person, but they are on the horizon and they do seem to work. So thank you very much.
So we open the floor for discussion. Any questions?